Hi, everybody. Here we are with Chapter 40. Um, this is Chapter 40 out of Chapters 39, 40, and 41. We're going to talk about nutritional problems that go along with the gastrointestinal system. So we're going to talk about nutritional problems. Nutrition is the sum of the processes by which one takes in and uses nutrition. So we're going to talk about undernutrition, normal nutrition, and overnutrition. So the nutritional status of a person or a family is influenced by many factors that include attitudes, eating habits, cultural and religious preferences, and financial status. Ingestion of a balanced diet includes carbohydrates, fats, proteins, vitamins, minerals, and water. Our government has come up with a website called MyPlate, and the website is on here, www.choosemyplate.gov, which is an approach to nutritional education, which provides a visual guide for a sensible meal planning and to help Americans eat healthful and make good food choices. So if you have any questions, you can go right there. America has gone overboard with eating habits. Here is a look at what is suggested with MyPlate. Vegetables, fruits, grains, proteins, and dairy. This is your proportions of what you should have. Obesity has become a real problem in the United States. So your normal nutrition should be daily caloric requirements of a person. Definitely are influenced by body type, age, gender, medications, physical activity, and the presence or absence of disease. So this is saying for men, your energy expenditure is equal to 5 to 10 weight in kilograms plus 6.25 height in centimeters minus 5 in age. And you can go out and figure all of this out. There's a couple of ways to figure this out, but the more convenient way to estimate the daily calories needed is based in kilocalories per kilogram, and an average adult requires an estimated 20 to 35 calories per kilogram of body weight per day, and that's using an appropriate reference weight. So our essential components of basic food groups are carbohydrates, fats, proteins, vitamins, and minerals. Carbohydrates are our primary source of energy. Every gram of carbohydrate is equal to 4 kilocalories. The chief protein-sparing ingredient it's composed of 45 to 65% of our daily caloric needs, and should include 14 grams of fiber per 1,000 calories. And we have simple and complex carbohydrates. So the simple carbohydrates are things like glucose, fructose, and these are found in fruits and honeys. We have things like sucrose, maltose, lactose. These are found in table sugar, malted cereal, and milk. We have complex carbohydrates, and these are things like starches such as cereals, grains, potatoes, and legumes. We have fats, and fats are a major source of energy. They're carriers of essential fatty acids and fat-soluble vitamins. They should make up 20 to 35% of your total daily caloric intake, and they have 9 kilocalories per gram. The harmful fats are saturated and trans fats. Healthier fats are monosaturated and polysaturated fats. And heart-healthy fats are considered polyunsaturated and omega-3 fatty acids. These are less risk to coronary artery disease. Proteins. These are essential for tissue growth, repair, and maintenance, body regulatory functions, and energy production. Proteins are obtained from animal and plant sources. They are 4 kilocalories per gram. 10 to 35% of daily caloric needs should be made up of proteins. And there are essential versus non-essential amino acids. Here's a picture. We're going to see this picture several times, but this gentleman obviously is malnourished, and we'll talk about this in a couple of different ways. So here is a nutritional label. A few years ago, our FDA went through several changes with nutritional labeling, and this is what our nutritional labeling looks like today. Very colorful. So essential amino acids come from dietary sources. We have two types, complete and incomplete. So a complete amino acid, it contains all essential amino acids, and things like milk, eggs, and meat are complete amino acids. Incomplete lack one or more of the essential amino acids, like grains, nuts, and seeds. However, a non-essential amino acid can synthesize the rest of the amino acid if the protein is available. The body can do that for us. Vitamins, they're an organic compound required in small amounts for normal metabolism. They're divided into two categories, water-soluble and fat-soluble. So water-soluble vitamins are things like vitamin C, B complexes. Fat-soluble are vitamins A, D, E, and K. Because the body stores excess fat-soluble vitamins, there's a potential for toxicity when too much is consumed. So the upper limits have been established for vitamins A, D, and E. We also have mineral salts, and those are listed on your screen. They're necessary for building tissues, regulation of body fluids. They assist in various body functions. So the major minerals are calcium, chloride, magnesium, phosphorus, potassium, sodium, and sulfur. Special diets. We have vegetarian, and this is usually an exclusion of red meat from the diet. Vegetarians, they get their plant protein from plants, although a lesser quality of protein comes from plants. Combinations of vegetable protein, such as cornmeal, kidney beans, can increase the nutritional value. Milk made from soybeans is also an excellent source of protein. We also have vegans, and they eat only plant food. This lacks vitamin B or cobalamin, and they can develop megaloblastic anemia and have neurologic signs of deficiency. So if you've got say a 19-year-old female vegan with symptoms of paresthesias, numbness, tingling in the fingers and the feet, this might be an indication that there's a deficiency in cobalamin, and that would be a need for supplementation. So symptoms of paresthesias would be an indicator that there's for a young vegan a need for vitamin B12 supplement. Lacto-ovo vegetarians eat plant foods and sometimes dairy products and eggs. We watch for vitamin and mineral deficiency and also iron deficiencies. And as nurses, we need to make sure that we are aware of cultural considerations. So some religions such as Judaism and Islam have specific laws regarding food. It's important for you to assess the extent to which Judaism or Muslim patients adhere to kosher or halal dietary practices so that appropriate meals can be served when caring for patients in the home or the hospital. It's also important to know whether the patient eats traditional foods associated with that culture. If traditional foods are eaten, assess for their impact on the health. For example, soul food, which indicates or include traditional foods eaten by some African Americans, tend to be high in fat, high in cholesterol and sodium. Some foods eaten by Asian Americans might be high in fiber and low in fat and cholesterol, but also low in calcium. And it's also is low in milk products. So it's important to know cultural tendencies. Okay, so let's go on to malnutrition. Malnutrition can refer to alterations in macronutrients, carbohydrates, proteins, or fats, or micronutrients, electrolytes, minerals, or vitamins. Undernutrition is poor nutrition due to inadequate diet or disease, and overnutrition is ingestion of more food than is required. Starvation-related malnutrition can be primary protein caloric malnutrition, PCM. Nutritional needs are not being met, chronic starvation without inflammation, and anorexia. Many terms have been used to describe the types of etiologies of adult malnutrition. Older terms are still used in some settings, including primary and secondary protein calorie malnutrition, PCM. Here's this picture again. Notice that this gentleman has the beginning of breakdowns on his bony prominences of the hip there. So chronic disease-related malnutrition or secondary PCM occurs when tissue needs are not met, even though the dietary intake would be satisfactory under normal conditions. It can be sustained mild to moderate inflammation, and conditions include organ failure, cancer, rheumatoid arthritis, obesity, and metabolic syndrome. It can be associated to acute disease or injury-related malnutrition. There can be marked inflammation. It can also be caused by major infections, burns, trauma, and closed head injury. So food basically is security. It's accessed by people, we hope, at all times to sufficient food for an active and healthy lifestyle. Individuals or families with limited financial resources may have insecurity or inadequate access. And if you've ever been around anybody that lived through the Depression, I bet you if you look in their pantry or their cupboards, you're going to see a storage of canned foods because they went without. Physical illness can be caused from illnesses, from surgery, from injury, from hospitalization. Malabsorption syndrome, we'll talk about that malabsorption syndrome is impaired absorption of nutrients from the GI tract. It decreases in digestive enzymes, reductions in bowel surface area, or drugs that cause undesirable GI side effects, and can quickly lead to a deficiency state. So fever usually accompanies many illnesses, injuries, and infections. with a concomitant increase in the body's base metabolism rate, which increases the need for food. Vitamin deficiencies are rare in developing countries, but in third world countries, they're not. But when vitamin imbalances do occur, they are usually found among persons with a pattern of alcohol and drug abuse, persons who are chronically ill, and individuals who are following poor dietary practices. And if you've ever worked in an ER or hung out in an ER, you're going to see people that have an addiction to either drugs or alcohol coming in that fit this syndrome. So malabsorption is, again, this is impaired absorption of nutrients from the GI tract. It results in decrease in enzymes. It can have drug side effects. It can decrease the bowel surface area, decreasing absorption. Fever increases the BMR. Vitamin deficiencies are okay. And we just said all of that. So food and drug interactions, we look for incompatibilities in drugs that may be causing this, altered drug effectiveness, impaired nutritional status. We also look at over-the-counter drugs, herbs, and dietary supplements. So the starvation process, initially the body uses carbohydrate stores from the liver and muscle to meet metabolic needs, glycogenolysis, and then from the liver and the skeletal muscle rather than fat and proteins. And once the body works its way through that, then it eventually goes to the body organs. Usually it takes about 18 hours without food intake before it has to go into the anaerobic type of metabolism. So once the stores are depleted, protein is converted from glucose for energy. Glycogenesis occurs, and that's formation of glucose by the liver. Alanine and glutamine are the first amino acids to be used by the liver for the formation of glucose in a process called glucogenesis. And with these amino acids being used as energy sources, the person may be in negative nitrogen balance. And within 5 to 9 days, the body fat is fully mobilized to supply much of the needed energy. And that's what that slide says. Prolonged starvation, 97% of the calories from fat and protein is conserved. Fat stores are usually used up in 4 to 6 weeks, depending on the amount available. Once the fat stores are used, body proteins are no longer spared. Liver function is impaired, protein synthesis diminishes, the plasma oncotic pressure decreases, and there's a shift from vascular space to interstitial space. Albumin leaks into the interstitial space and edema results. And at this point, when albumin starts leaking into the interstitial spaces, then we can see edema. And so I need to stop here. If you have an elderly patient that has a BMI of 17 and a low serum albumin level, you would expect to see pitting edema. That's a sign of starvation, malnutrition, but it's the combination of the low albumin level and the pitting edema. When you put those two things together, that gives you the clinical picture. So it's the leaking of the albumin into the interstitial space that gives you the low albumin level and the pitting edema. The other clinical picture, we're going to see skin is dry and wrinkled. We're going to see the failure of the sodium-potassium pump. a deficiency in calories and proteins, the liver loss, a loss in liver mass. It becomes infiltrated with fat. The diet of protein and other constituents must be initiated or death will occur. Okay, sick people have an increased nutritional need. It's not uncommon consequences of illness, surgery, injury, or hospitalization. When we get somebody that's chronically ill or has a major injury, we automatically up their caloric intake because it takes energy to heal. During the starvation process, there is a decrease in the BMR, sparing of skeletal muscle, and decrease of protein breakdown. In inflammatory states, alteration in the expression of pro-inflammatory and anti-inflammatory cytokinins appear. Cytokinin changes result in, and I'll let you read this. You should remember all this from last semester. Mild emaciation results in, we can see those changes in the skin, the nails and the hair, the mouth, the tongue. So we're going to see dry and scaly skin, brittle nails, rashes, hair loss. The mouth will be crusting and ulceration, changes in the tongue. Muscles, we'll see a decrease in muscle mass and weakness. We'll see central nervous system changes, mental changes such as confusion and irritability. This is unrelated to nursing school. Protein intake is severely reduced. The muscles become wasted and flabby, leading to weakness and fatigue. The person is more susceptible to infection. Anemia is usually the result of nutritional deficiencies related to iron and folic acid. And these are the necessary building blocks for red blood cells. And so here's a picture again. So when we talk about doing exams, diagnostic studies, of course, we want to do a history and physical. We look for a food history for the past few weeks. And that might be to the point where we actually ask a patient, what have you eaten? What have you eaten in the last day? What have you eaten in the last few days? What have you eaten in the last week? Ask them for a food diary. We look at their height, their weight, their vital signs, physical examination. This is a summary, summarizes their recent nutritional health. We're going to look at their lab results, their albumin, serum albumin, pre-albumin's serum transferrin, C-reactive protein, electrolytes, complete blood count. We're going to look at their arthropometic measurements, look at skin fold thickness at various sites. This is a fairly reliable measurement. Their mid-arm circumference. Compare that with standards for a healthy person. And then look at their functional measurements. We want to do a nutritional screening within 24 hours of admission. We can use the mini nutritional assessment and the minimum data set assessment. What we're looking for are changes in weight, again, a diet history, we're looking for drug usage, laboratory test results, physical examination, again, the anthropometric measurements. In older adults, the MNA is used in long-term care setting. The MDS form is used for this assessment. A loss of 10 pounds in a 6-month period, whether it's intentional or unintentional, is considered a critical indicator for further assessment, especially in an older patient. So we're looking for imbalances in nutrition, less than body requirements. If someone's not eating enough, if they don't take in enough calories, then they will have an imbalance. We're looking for any kind of a feeding self-care deficit, a deficit in fluid volume, a risk for impaired skin integrity, and non-compliance. And these are all nursing diagnoses that you might put in place. Planning-wise, we're going to look at a patient with malnutrition. We want them to achieve weight gain in a particular muscle mass. We want them to consume a specific number of calories per day. We want them to have no adverse consequences related to malnutrition or nutritional therapies. We want to promote health, and ambulatory and home care if necessary. So we're going to do this by encouraging daily calorie count, high protein, high calorie foods, and that is kind of a concept I want to talk about for a minute. Just think about what it would be like if you didn't have to watch your weight, if you could go out and have anything that you wanted. So suggestions to, let's say, an elderly person that needed to bulk up on calories. What kind of a diet could you suggest if you're trying to get them to eat more and more high-calorie foods? So let's think about a chicken dinner. If you were going to have a chicken dinner, what form or fashion of chicken would you want them, and we're going for calories here, would you want them to have baked chicken or fried chicken? What's higher in calories? Nothing like a good old-fashioned southern fried chicken, is there? What kind of a vegetable would you want with that? Again, we're going for high calories. Now let's start them off with some potatoes. Maybe some mashed potatoes would be good. And could we smother that with some gravy? Because for this person that needs calories, let's give them some calories. So let's give them some mashed potatoes and gravy. We can throw something green in there if you want to. But we want a high-calorie diet for these patients. And the chicken gives them protein. The potatoes are going to give them carbohydrates, and something green would give them something good. Okay, if somebody is not able to eat large meals, I don't have the appetite, I can't tolerate, then we switch modes a little bit and we say, let's do multiple small feedings. So instead of 3 large meals, we might give them 6, or 3 large meals, we give them 6 small meals. Or maybe 3 medium meals with snacks in between. We also talk about using dietary supplements, and we'll talk about this a little bit later too. We can use appetite stimulants. We can do diet diaries, dietary consults, and we record all of this with discharge instructions and make sure that's written out for the patient, because they won't necessarily remember everything that we send home with them. Okay, and then we have to evaluate everything. So what we want is for the patient to achieve and maintain optimal body weight, consume a well-balanced diet, experience no adverse outcomes related to malnutrition. For our gerontological considerations, we know that our older patients are going to be at risk. There are physiological changes with oral cavities, dentation, teeth problems or lack of teeth problems, digestion and motility, endocrine system. And again, as people get older, sometimes their symptoms get confused. We don't know if it's an actual disease process or simply aging. musculoskeletal system issues, and then vision and hearing. If they're too tired to eat the multiple small meals. Comfort foods, if they're not liking hospital meals, or if they're in a nursing home, you might ask family members to bring in home cooking or some of their favorite meals. When we talk about lab values, think about your normal lab values, especially when we're talking about metabolic malnutrition. If you have somebody with a low potassium, is that something that you would report to a provider? I think it would be. So know your normal lab values. Another indicator, if you've got a patient that has been malnourished, if they have a surgical incision that is now healing correctly or healing normally, that's an indicator that we're starting to correct that nourishment issue. All right, let's go on to enteral nutrition, and that's tube feeding. Enteral nutritions or oral feedings are high-calorie supplements. They're used when nutritional intake is at a deficit or deficient. It includes things like milkshakes, puddings, and Ensure and Sustacal. These are not meant to be meal substitutes, but they're meant to be snacks in between. Here is a chart. I'll let you come back and look at that when you want to. Enteral nutrition is also known as tube feeding. It's administration of nutritionally balanced liquefied food or formula. It's given through a tube inserted to either the stomach, the duodenum, or the jejunum. It provides nutrients alone or supplemental to oral and parenteral nutrition. It's easily administered, safer than parenteral, more physiologically efficient than parenteral, and less expensive than parenteral. Indications include those with anorexia, oral facial fractures, head and neck cancer, burns, and nutritional deficiencies. Also neurological considerations, psychiatric considerations, chemotherapy, and radiation therapy. We can provide these through a continuous pump infusion, through intermittently by gravity, through a bolus with a syringe, or through cyclic feedings with an infusion pump. Here is a wonderful picture that shows different sites. We have a nasogastric site. We have an esophagotomy site there in the neck. Then we have a gastronomy site on the right side top, a nasoduodenal site on the left. I'm not sure exactly what that's showing us. And then jejunoscopy on the right. So nasogastric and nasointestinal tubes are inserted through the nasal cavity. They are radio opaque so that we can see them on X-ray and visualize that we have them in the right place. The likelihood of regurgitation and aspiration decreases when they're placed in the intestine. However, the likelihood that somebody will grab them and pull them out because they're irritating is quite high. They can be dislodged by vomiting or coughing, and they can also be knotted and kinked in the GI tract. Gastronomy and jejunostomy tubes are used for those needing tubes that are going to be in for extended periods of time. Patients must have an intact, unobstructed GI tract. They can be placed surgically, radiologically, or endoscopically by endoscopy. Here is a picture of a gastrostomy tube. Here is another picture of placement of a PEG tube. This is done with endoscopy. So a PEG tube requires esophageal lumen wide enough for the endoscopy. Is radiographically placed. There's fewer risk than surgical placement, lower cost, and minimal sedation. Gastrostomy tube placement is via percutaneous endoscopy. These are usually the most popular that we see. It's inserted through the esophagus into the stomach, and then it is pulled through a stab wound made in the abdominal wall. Feedings can be started with when the bowel sounds are present, and usually that's within 24 hours after placement. Immediately after insertion, the tube length from the insertion site to immediately after insertion, the tube length from the insertion site to the distal end should be measured and recorded. Tube should be marked at the skin insertion site, and insertion length should be checked regularly. So tube feeding administration, the patient position, the patient should be in a sitting or lying with the head of bed up 30 to 45 degrees. The head of the bed remains up 30 to 60 minutes for intermittent delivery, and this is to reduce the risk of vomiting. We always irrigate with water before and after each feeding, drug administration, and residual checks. Continuous feeding administration on feeding pump with an inclusion alarm, we will stop that and check for residuals because we want to make sure that we're not overloading the patient. Placement check before each feeding, drug administration, or every 8 hours with continuous feeds. And I bet that you have done this in your clinical labs. Tube position methods to check the placement. We aspirate stomach contents and do a pH check. If it's less than 5, this is indicative of stomach contents. And then we can also visualize with X-ray. Tube position, increased volume leads to increased aspiration. So we always check that. Formula, we use commercial formulas. They are preferred to blenderized foods, and we like them to be room and body temperature. If you reconstitute something or dilute a commercial formula, make sure you are using a sterile water and that you refrigerate that and dispose of it after 24 hours of reconstitution. If you're using a pump, gradually increase the rate or volume over 24 to 48 hours with checking the residual routinely, whatever the doctor writes or the hospital policy is. Intermittent feedings volume is usually 200 to 500 mils per feeding. And then we administer flush water before and after so that we know that it's being tolerated. We do daily weights. We assess for bowel sounds before feedings. We keep an accurate INO. We do glucose checks. We label with date and time when it was started. And we do pump tubing changes every 24 hours or whatever the hospital protocol is. Complications that you might see are vomiting, diarrhea, constipation, dehydration. You can see more calorically dense, less water formula contained. And you can also check for high protein content. Remember, even though they're getting a lot of liquid, you still have to give the patient water. They have to have water along with this. You're going to see two major problems. One will be skin irritation. So you must assess the skin at the site of the entry of the J tube or the PEG tube. And then pulling out of the tube, teach the patient and the family about feeding administration, tube care, and complications. And then gerontological considerations. Be considered of fluid and electrolyte balances of the patients, glucose intolerance. So we're going to be doing AccuChecks. They have a decreased ability to handle large volumes and an increased risk of aspiration. So let's see. A patient that is getting a full strength tube feeding formula at 100 an hour has diarrhea stools the first day. Let's say they have anywhere from 5 to 7 diarrhea stools. Might indicate that we need to slow that infusion rate down. We would need to report that to the provider first. But I would definitely slow that infusion rate down until I hear back from the provider. We've probably given the patient too much right off the bat and might need to work that rate back up. When we put in a PEG tube, we're going to check the residual volume every 4 to 6 hours after we started feedings. We always flush and check residual volumes when we're doing an NG tube. Anytime we put down feedings, anytime we give medications. If a patient is scheduled for a CT scan, we need to shut off the tube feeding 30 to 60 minutes before they go for the exam. It's just like being NPO. If they're getting a feeding and they have an exam scheduled that it has some kind of an NPO regulation, that goes for the tube feeding. The tube feeding gets turned off. So for a CT scan, we're going to shut that tube feeding off prior to the exam. Okay, let's go on to parenteral nutrition, and this is chapter 40. Parenteral nutrition is administration of nutritions by routes other than the GI tract, so this leaves the bloodstream. We use this when the GI tract cannot be used for ingestion, digestion, or absorption of essential nutritions. So this would be for patients who sustain severe injury, surgery, burns, or those who are malnourished as a result of medical treatment or disease processes that have greatly increased nutritional needs. The goal is to meet nutritional needs and allow growth of new body tissue. We're going to use regular IV solutions. That can be dextrose in water or dextrose in lactated ringers. No protein. It'll be 170 calories per liter. Normal adult requirements, minimum of 1,200 to 1,500 calories a day. Regular dextrose solutions could exceed capacity of cardiovascular systems. So, and again, in cases of injury, surgery, burns, malnourishment, these cause increased nutritional needs. So, chronic or intractable diarrhea and vomiting, complications for surgery or trauma, GI obstruction, GI tract anomalies and fistulas, and malnutrition are all reasons that we would, or indications for parenteral nutrition. Administration of the nutrients by other routes. So the base solution contains dextrose and proteins in the form of amino acids. There's also prescribed electrolytes, vitamins, and trace elements. And sometimes there's a fat emulsion to complete the nourishment. The hospital will usually have a standard PN order, and then doctors can either go off of that or use that. Calories are supplied by carbohydrates in the form of dextrose and by fat in the form of fat emulsions. up to 30% of the total calories from the fat, and less fat concentrations for critically ill patients. Protein is 45 to 65 grams daily, and the requirements are increased as in nutritionally depleted patients to ensure a positive nitrogen balance. Electrolytes are, the individual requirements are assessed and based on what the patient's needs are. Trace elements and vitamins are included, so they're going to consider things like zinc, copper, chromium, manganese, and you can read those. Methods of administration, we can put them in through a central line for long-term support or a peripheral line for shorter-term therapy. So central parenteral nutrition is through a catheter where the tip lies in the superior vena cava, and that's usually through a subclavian or jugular vein or through a PICC line, and it's meant for long-term. Peripheral is through a traditional IV access. Short-term, in the case where a risk of a central catheter is too great, or just to supplement inadequate oral intake. Central solutions are hypertonic, actually so are peripheral. And the glucose content is ranging from 20 to 50%. In the peripheral solutions, the peripheral vein can handle glucose up to 20%. Parenteral solutions are prepared by a pharmacist or a trained technician under strict aseptic technique. They must be refrigerated up to 30 minutes before use, and they must be labeled with nutritional content, time, mix, and date, and time of expiration, and check your facility to see what their policy's on. Usually they don't hang more than 24 hours. Catheter placement of a central line is done under sterile condition by a physician or an advanced practice nurse. Isotonic IV solution is infused until X-ray confirms the correct placement. The site is covered with a sterile dressing, and the date is marked on dressing. And let me go back to this catheter line insertion. I think you were taught in Adult Health 1 that you don't run anything through a central line until placement is confirmed, and that is true. I don't know why this says isotonic IV solution infused until X-ray confirms correct placement. That is not correct. You do not run anything until placement is confirmed with a X-ray into a central line. One of my very favorite doctors actually had a patient that died because something was run in a line that had not been checked. Complications of parenteral nutrition is refeeding syndrome, and this is a fluid retention and electrolyte imbalances because of because of parenteral nutrition. Long-standing, let's see, so it's characterized by hypophosphatemia, hypokalemia, hypomagnesemia. Conditions that predispose the patient to refeeding syndrome include long-standing malnutrition, such as chronic alcoholism, vomiting and diarrhea, chemotherapy, and major surgery. It can also occur anytime a malnourished patient is started on an aggressive nutritional support. So hypophosphatemia is the hallmark of refeeding syndrome, and it's associated with a serious outcome. And that includes cardiac dysrhythmias, respiratory arrest, and neurological disturbances, such as paresthesias in the fingers, the feet, the toes. Metabolic problems, hyperglycemia, hypoglycemia, pre-renal azotemia, fatty acid deficiencies, electrolyte disturbances, hyperlipidemia, mineral deficiency. These are all things that we look for. Mechanical problems, we can have insertion problems with the actual line, dislodgement with the line, thrombosis of a great vein, or phlebitis. And again, we look at for that every time we do a line check, we do a site check, we hang a bag, we're always looking at that line. We do vital signs every 4 to 8 hours. We do daily weights, blood glucose. And anybody that's on a parenteral nutrition, regardless of whether they're diabetic or not, is going to be getting blood glucoses every 4 to 6 hours. And probably your parenteral nutrition is going to have insulin in it. We're going to do routine labs that will include electrolytes, BUN, and CBC. We're going to do liver enzymes. We'll do dressing changes at the site. We're going to look for refeeding syndrome. These must be, PN must be run on an infusion pump. And we need to periodically check the volume infused. So what would you do if you had a patient that had lung sounds that were clear bilaterally and by end of shift? You had crackles in the bases. Is that normal? Maybe not. Maybe that's something you would call for. So a good lung assessment when you're running parenteral nutrition, because we're adding volume to the patient's vascular system. Before administering, you're going to check the label and ingredients against the order. Examine the bag for signs of contaminant. Make sure you're scanning your patient, scanning your medication, because it is a medication. You're going to watch for signs of infection and septicemia. Local manifestations would be erythemia, tenderness, exudate at the catheter insertion site. Hopefully you're not going to see that because this is a covered site. Systemically, you'll see a patient will complain of chills, fever. You'll see nausea, vomiting. They'll complain of malaise. We'll look for blood and catheter cultures, or we'll get blood and catheter cultures if an infection is suspected. We will do x-rays to check for changes in pulmonary status. And after parenteral nutritional therapy, we'll do daily dressing changes until it heals after we take that catheter out. Sometimes patients have to go home with this. So we teach the patient and the caregiver about catheter and tube care, mixing and handling of solutions, side effects and complication, and discharge planning as needed. Anything we tell them, we have to write down and send that home with them because they won't remember. If they're getting parenteral nutrition at home, it will have to be delivered to them on a daily basis because it cannot be mixed at home. This is expensive. It has to be covered probably by insurance unless they're independently wealthy or win the lottery. They're going to need assistance with reimbursement, which automatically brings in social services. They'll need resources and peer support. And then the last two things are eating disorders. Anorexia nervosa is a self-imposed weight loss disease. It's an endocrine dysfunction. It has a distorted attitude toward weight and eating. And then bulimia nervosa is a binge eating, self-induced vomiting. It is a loss of control related to eating, persistent concern with body image. So what if you've got a patient, let me back up to parenteral nutrition. I think I made the comment that most PN has some insulin in it and the patient will be on routine AccuChecks. What if you had a patient that had an AccuCheck of 120? That's a little bit above normal. What would we do with that? Do you think you would look for a sliding scale to dose with? Do you think you would call a provider? I think that the best answer for that is that we would recheck that in 4 hours because that is a little bit high, but it's not extremely high. And let's just consider that this patient is new to PN and it might take just a day or two for them to level out. If after 4 hours that AccuCheck is still high, then we would place a call to the provider and see if we needed to do something. We may not dose with insulin. What they may end up doing is decrease or increasing the amount of insulin in the PN for the next day. So check your facility for their policies on tubing changes for PN. If it's time for a new bag and the infusion is about to run out, let's see, but the bag is not there yet from pharmacy, hang a bag of D5 until it gets there.